Hello, good morning, good afternoon, good evening, wherever you are watching the world, and welcome to Chatham House in London. My name is Robert Yates, and I'm the Executive Director of the Centre for Universal Health at Chatham House. Well, welcome to our third virtual policy dialogue, specifically looking at cancer services in the era of COVID-19. This series is very kindly sponsored by Merck Sharp and Dohme. And it's the third meeting, as I say. The first two really focusing particularly on the healthcare needs of the elderly in our first meeting. Secondly, we were looking at the worrying trend for COVID-19 pandemic to displace cancer services and the threat that really represented to extending cancer services. This third meeting, rather than sort of focusing on what's been happening at the moment, I think is going to be a bit more forward-looking, sort of recognizing now that we are learning lessons from COVID-19 and the impact it's having on health sectors, health services across the world. What lessons can we learn from this? And really building on the opportunities this is thrown up. I have a very distinguished panel with me today to discuss this topic. Before I introduce them, though, I'd very much like to ask you, the audience, to participate today. We're very keen to get your views, your questions of our panel. And the way that you can participate is through asking your questions through the Q&A function. At the bottom of your screen, you'll see Q&A. And if you could type in your question, maybe directing it at a specific panelist or to the panel in general. And if you like, we can bring you on air. We can promote you to be a panelist as well. And you can ask your question either through audio or through video as well. And we very much encourage you to do that. So if you'd like to flag that you would like to ask your question, then we'd be more than happy to bring you on board. I should say as well that we are on the record today. In fact, the meeting is being recorded, so we're not following the famous Chatham House rule. It's not just amongst us that we're discussing this. We're very much wanting to share these views around the world, and we very much encourage you to be very open in your dialogue with us. So our panel today, a very distinguished panel of people all over the world. And first of all, we have Mariana de Camargo Cancela, who's joining us from Brazil. She's an associate researcher at the Brazilian National Cancer Institute, and she's going to give us the perspectives of what's happening in Brazil at the moment vis-a-vis cancer services, but also looking worldwide at the situation. Then looking specifically at technological advances and the innovations that we could potentially build on, we have Mariana Emenecueva, who is the founder of Link to Medicine, which is an IT consultancy company focusing specifically on deployment of digital health solutions. And finally, we're going to be hearing from Carrie Adams, who is the CEO of the Union for International Cancer Control, of course, a great figure in the global cancer world. And he's going to be very much, again, looking to the implications of the COVID-19 crisis and what this might mean for not only maintaining, but extending health cancer services into the future. So my panelists will speak for about 7 minutes or so each. And then we're going to have the opportunity to throw it open for questions and answers. But do please feel free to ask your questions and answers right from the outset. And if there's a particular question that you like that someone's asked already, if you can say upvote it, you'll see a little thumbs up sign. That'd be a way of getting that question promoted up the table. So we'll ask the most popular questions. So do feel free to start asking questions right from the very outset. So without any further ado, if I can turn to Mariana in Brazil and ask you, looking at the COVID-19 crisis and cancer services, not only in Brazil, but elsewhere, what do you see as the big implications for cancer services going forward? Mariana, thank you.
Okay, well, thank you for this introduction, Robert. It's an honor to participate to the session, to the discussion. Well, what I think it's in the world as a whole, COVID-19 has exposed the fragilities, not only from health systems, but also from the societies And as it happens with cancer, the most hardly hit and are the most fragile, both in terms of prevention and access to care. Of course, there was a certain disruption in buying equipment for individual protection and everything, because there was all the world rushing to buy everything. So there was some difficulties in acquiring these equipments for cancer care. But I'd like to go a bit further and talking not only about the cancer care, but about the inequalities that we can make a parallel between cancer and COVID-19. So the inequalities, they started the exposure to risk factors as for several cancer types, especially preventable ones. So when we see like smoking and obesity prevalence are higher in more deprived populations and crowded houses, so which difficult the prevention of the disease. And not only when you have you are at increased risk and you have difficulties to access in different levels. And so the more deprived also experience in countries in transition, principally a double burden of disease. So including within the COVID-19 crisis, as the non-communicable disease increased the odds of developing more severe forms and lead to death. So they are really hardly hit. And the infection-related cancers, for example, and premature deaths from those cancers are also more common among vulnerable populations. So COVID-19 has exacerbated all of that. Also, another point which I already worked with is ageism, the age discrimination, which was already observed in cancer treatment. Where older people tend to not have optimal treatment based only on their biological age and not their general status. And we see this with COVID-19 saying, okay, it's a disease that will only hit hard older people. We are young, we don't have nothing to care about. Like, in general, in all societies now, especially now with the second wave coming, it's mostly among younger people. Well, having said that, COVID-19 provided some initiatives to improve access to healthcare. Well, here in Brazil, we had some initiatives with telemedicine as the major example, the development of an app to inform people about the symptoms, whether they look for a doctor or not, a hotline also. And in some cancer centers to avoid unnecessary exposure to fragile cancer patients when adequate and not necessary to have a physical consultation. So they had the follow-up by telemedicine, and also preclinical video consultations were available for those experiencing COVID-19 symptoms. Well, of course, there will be an impact that we don't know yet, which will be. We have like patient delays as well in several illness, not only cancer. Well, the number of heart disease and things like that, where people they are afraid of looking for medical services. So this is also expected for cancer. So I think both developed and developing countries will face many challenges in keeping the acquired progress in cancer control at all levels. And especially the developing countries will have to make efforts to keep the progress, and they still having the need of several improvements in terms of both cancer prevention and care, and have to keep the progress acquired. So there's a lot of work there. And the relationship between socioeconomic status and chronic conditions in low and middle income countries is very well established. And the progress will only be achieved when those inequalities are tackled. And the main question is how to do both. And for example, we have also hard to reach population both physically, like living in the Amazon forest, or really hard to reach inside the cities due to differences in education and in health literacy. And so this raises many other questions concerning infrastructure, well, access to digital devices, access to networks, and I think the most important is health literacy, which will be only available and achievable through education. So there's need of the involvement of multiple actors in these initiatives if you want to maintain what we acquired in cancer control, and if you want to keep advancing in the areas and populations more vulnerable. And so I think these opportunities presented by COVID-19 can help us to think about better planning and a better use of available technological resources, and to research new ways of reaching populations in universal health systems. Well, just to close, I'd like also to highlight, well, that's my specialty, the importance of a good quality health data system in order to adequately plan policies and initiatives, and to make the follow-up of everything to see what works, what doesn't work. So for this, cancer registry data is fundamental, and we saw that even with infectious disease, which is really need to follow up, we need information timely. All countries experience some problems at some point to have this disease surveillance. So that's it, and I think the information technology can help a lot with that. So thank you for your attention, and I hope I was in time. Thanks.
Perfect timing, Marianne. Thank you very much indeed, and excellent that you raised the issue of inequalities and sort of bringing sort of COVID-19 and cancer together and spotting the the similarities there, because so much about reaching universal health coverage is that health services should be allocated and consumed according to need, and there are obviously huge issues being raised about rationing of health services, who gets treatments and services first at these difficult times, and these are as much political issues as they are technical issues, and I'm sure this is something that our audience will have views on, and we encourage you to ask questions around these issues about how do you prioritize who gets services first in this situation. You also mentioned the importance of data systems and information, and that's a sort of a perfect segue into our second speaker, Mariana now in Romania. If you can tell us, it's very much about the digital future and how one is going to embrace digital technologies and extending services and also hopefully making them more equitable too. Mariana.
Hello to everyone. I hope you hear me well.
Very well.
So thank you for inviting me for this interesting discussion. And yes, indeed, the COVID-19 pandemic is a very challenging test for all digital health solutions to prove how reliable and agile they are in the new circumstances. And generally now when we speak about telehealth, we growth. And a few numbers like 4,000% growth in the United States, or 100,000 physicians in Germany which connected to video platforms during only 2 first months of the lockdown. All of these numbers, they prove that it's really growing. But what is behind this growth for us healthcare IT specialists? So during the first phase of slowing COVID-19 spread, many healthcare organizations experience a very rapid and, let's say, extremely radical transformation from in-person care to telehealth visits. And they had to embrace to speed up this adoption process. And we know that the process takes usually months of piloting, implementing, and training. So majority of healthcare organizations, they worked on a temporary solutions like Skype, FaceTime, or even phone, and this is great. But this for us means the lack of interoperability, connecting data to HR systems, and many cybersecurity issues, which we also faced in many places in hospitals around the world. So majority of very important functions of telehealth, like reimbursement, e-scheduling, e-prescribing, were absolutely out of scope. So from one side, this experience which we had, it's very useful to establish the communication channel, which actually we use every day, using FaceTime with our relatives and so on, with the family. But from the other side, knowing that telehealth means much more than this. So these results should be analyzed, and I hope that we will face the new phase of implementations, which will bring the real telehealth solution into the field. And thanks to all my colleagues in HIT who voted, who went with all the solutions, because now on the market we have more than hundreds different telehealth solutions for different types of patients. And if we think about other technologies, which are also relevant to the cancer care, I think it's all about data. And good lessons we learned during this COVID-19 pandemic, that we should trust data, because many difficult decisions about implementing lockdown, about exit strategies, about reopening economies were made based on data and the way how different countries actually interpreted this data. And the topic of wide gathering data, data analytics, artificial intelligence, machine learning, unfortunately, it's conversation about implementations which we cannot make overnight. Yeah, can you hear me well? Yeah. So I think the good example here are countries where a strategic approach was implemented and cultivated for years. And probably Israel is one of these good examples. Having a history of EHR use and now data analytics plus tracing systems, which they implemented, help them to identify the most critical groups of patients based on the history of their diseases, and add to this information the COVID-19 impact risk, which gives a score for every person. And using the tracing system, citizens can receive the information if they are in the group of the risk based on the recent contacts. So this, I think, is a very good example how technologies help community to resist during the COVID-19, and to have actually the next step plan. So I'd like to say a few words about innovations. We HIT specialists try to use the clinical problems to solution approach, which means that the matrix of issues and requirements from the cancer patients and physicians community should face with the matrix of possible solutions from healthcare IT. And to make the priorities more evidence-based.
Really struggling with.
Can you hear me well, Carrie? Mm-hmm. And to make priorities more evidence-based, we should support them with data. This is a very important point. And here the data about the impact of COVID-19 on the cancer patients will be very critical. So all studies which I found right now about this vote for the holistic contingency plan with guidelines, with details for each group of patients, taking, of course, into account the country's healthcare systems. So why it's important? This is very important in order to have a proper conversation with the government systems, to influence on decision-making process in terms of priorities, in investment, budgeting, legislations, and any other support. And here, what we discussed before with Carrie, I would like to put call to action to make the dialogue between the cancer community and HRT community more effective, more efficient, to have a constant innovation cycle possible, to find the proper IT solutions to the needs of cancer care patients, and to understand which technologies can actually help to support this holistic contingency plan approach. So this is my side from the technologies. Thank you.
Thank you very much indeed, Mariana. That's wonderful. And apologies, I've been having a few internet problems here in London. We're just about to have an almighty thunderstorm, I think. So this seems to have like completely thrown things. But now I'm sitting on top of the server, so we should be okay now. So thanks very much. And that's really excellent to get the the perspective about how technology is throwing open all these opportunities. And of course, the big buzzword at the moment is building back better. How are we going to build back better? And I think everyone recognizing that technology is going to be hugely important in not only extending access to cancer services, but literally all services across the spectrum. So now, if I may bring in as our final speaker, Carrie Adams, but before I do that, very much encourage you to ask questions of our panelists using the Q&A function. And this is our, as I say, our last webinar, and some of you may have been sort of joining all of them. And I'm very keen as well for you to have your say that, that if you sort of feel there have been any issues that we've addressed in any of the 3 sessions and that you want to come on air and share those with us, you will be more than happy to have your thoughts. So do feel free to ask specific questions of the panelists, but also more generally about how we're going to maintain access to cancer services coming out of COVID-19. But Carrie, you're sort of, I think, very much as well, sort of, moving us into this forward-looking viewpoint about how are we going to build back better? What are the implications for the future? So if you can get your crystal ball out and tell us, where do you think we're going? Thanks.
Robert, thank you very much for the invitation to be on this panel. And I always carry a crystal ball around in my pocket, so don't worry. There's plenty of things we can predict and no one can disprove me. First of all, I'd like to say well done to the other panelists. I thought they covered some excellent areas, and I will talk on those a little in my 5 to 6 minutes, just on the areas which I think we can learn, or we can grab the opportunities which have been created through the COVID pandemic. And I want to start off by saying that I'm not in any way belittling the challenges that the cancer community are having around the world. And I'd echo what the speakers have said before, that it's been incredible to see the ingenuity, the innovative spirit, and the sheer commitment to support cancer patients country by country, UIC member by member, to help those patients through this crisis as they've tried to get to their treatment, have their advice and guidance. And we've certainly seen the use of Zoom, and we've seen the use of applications and hotlines and everything else. And I know that a lot of people are very passionate about making sure that the cancer patient does get the service they require, even though there is clearly priorities that the governments have in some countries. So if I look forward and imagine a world where we're getting through COVID, I think there's some great learning from what we've experienced as a generation in the context of some of the things that we were arguing for in the last 10 years for non-communicable diseases and cancer. So the first one is that I don't think anyone can ever doubt that health really does impact economies. It really does. And I think that's been hard to argue in the past because it's been stuck in the health ministry and not necessarily gone into the finance or treasury of a government. They've been very distinct. They haven't necessarily worked together to understand the implications of one investment, but also the return on that investment in cancer treatment and care in the longer term. So I'm hopeful that one of the outcomes of this is that we'll be able to articulate investing in UHC, for example, investing in cancer treatment and care, prevention, as something which can be directly related to the economic welfare of a country going forward. And I'm looking forward to sitting down with some health economists and working out how we do that in the future. The second point, which is related, is that we have argued for many years that NCDs and addressing cancer is a whole of government affair. And it hasn't necessarily been picked up as a whole of government affair. We argue within the UIC community that every country should have a national cancer control plan, and that should be owned by the government, if not the head of state. But we still witness many NCCPs being owned by the health ministry and not being engaged right across the government. And I'm hoping that we will be able to use this as a platform to articulate why, on the issue of prevention, early detection, treatment and care, palliative care, there needs to be an engagement right across government in a national cancer control plan, with appropriately allocated resources so it can be implemented and it can have an impact over time. The third area I think is quite interesting is how do we use this masterclass of prevention that we've all gone through over the last 5 months in avoiding a disease. We know that 40 to 50% of all cancers are caused by risk factors which are well known, and I will not go on about tobacco, but we know tobacco is very much linked to cancer and the other NCDs. And it looks like tobacco use actually has a fatal potential impact on those who develop COVID. So how do we use this immense societal approach to avoiding a disease and build on that mentality to say, well, we can use the same approach to avoid NCDs in later life? And I think that's going to be an interesting discussion going forward. You mentioned earlier, I think Mariana from Brazil mentioned about the COVID has revealed the cracks in the health delivery of services to the rich and the poor. It really has exposed the differences and caused massive change in thoughts and pressure on governments around the world. And it's very true in the cancer space, NCD space. And I think we will need to look at how we can support governments address the delivery of health services in the UHC world, which means that appropriate services are delivered to any individual in a country, independent of their wealth or means. And I know the OECD is predicting that we will see a general increase in the spend on health from about, I think about 8.8% to 10.2% by 2030. I'm wondering whereas an outcome of this, we will see that increase and accelerate, because people will see that investing in health is the right thing to do. And with the commitment to the UHC, which we discussed at the World Cancer Leaders Summit last year, I think there's a real sense that people see this as the common ground upon which all disease groups can argue. We put UHC in and we put it in well, then we all benefit. The next thing is, I think we've also seen how governments have had to take a lead role in health. And the NGOs, whilst we are incredibly strong and we do a great job, we are being hit very, very hard with the financial consequences of COVID. And at a time when the community needs NGOs and charities to thrive and support cancer patients, we've seen only in the last couple of weeks, the American Cancer Society announcing 1,000 redundancies, Cancer Research UK announcing 400 or so redundancies. Income from most NGOs and charities around the world down 25%, 30%, and sometimes more. Now, the health system relies on that core infrastructure, that ecosystem of civil society to support the health system. And I think governments need to take more of an active role in recognizing their importance in the patient's journey and to make sure they're suitably funded, because what we are uncovering is that their funding is really fragile, and we cannot recover quickly unless civil society, the NGO and charity sector is given a support through that recovery process. And the last one, which I think, again, Mariana mentioned about the technology side, is I think technology and data may have come of age. I read an IARC report suggesting that the amount of issues and challenges they're having in cancer registries around the world has increased significantly during COVID because of the lack of personnel to actually collect the data. And we've argued long and hard with our colleagues at WHO and IARC that data it feeds evidence, evidence feeds policy, policy feeds output, feeds data. I mean, we need to get that cycle going. Unless there has been an impact on current registries, but the gap between where we are in our knowledge around the world on cancer and where it should be is enormous. We have whole swathes of the world where we have no cancer data. So I'm hoping that if it's the coming of age of data through COVID, the use of collecting information on apps and other technologies, then this may also be the decade of where we really get under the skin of the data challenge in cancer control. And by doing that, we become more cost effective and more efficient in dealing with cancer patients and dealing with the cancer burden. as it grows over the next 10, 20 years. So those would be my general observations, which are more learnings from what's happening and applying it to a 10, 20-year period in future. And I do conclude by saying that I'm quite optimistic, despite the sadness, the frustration, the annoyance, and the sheer devastation that COVID is causing around the world. I think that we owe it to ourselves as global health leaders to look to that positive opportunity that will come out of this. There will be a time after COVID. There will not be a time after cancer.
Yes, very, very good point, Carrie. And I fully agree with what you're saying about this throwing up opportunities to sort of take health and health reforms out of the health ministry and right to the forefront of the debates with ministries of finance, treasuries, but also heads of state. I mean, across the world, every single head of state at the moment, health and access to healthcare is top of their agenda. And I think, it is just inevitable coming out of this that we're going to see countries spending more money on health, expecting to get better value for money out of that. And I think that, this is our opportunity to get our act together, get more resources and have that spent more, more efficiently and more equitably. But, it's going to be a struggle to ensure that. And I think, this is our challenge for the global health economy, not to blow our chance. And we're not being opportunistic here. It's what people want, and we're going to be seeing this feature in many election campaigns at the moment. I'm sure it's going to be figuring very prominently in the United States election coming up. And I wonder, Mariana, when we might discuss what the situation in Brazil might be sort of going forward as well, sort of about the politics of all this as well. So, these are absolutely sort of crucial issues. So I'm very keen to, that we maintain this focus of looking forward, being as positive as we can about, sort of how we build on this opportunity. And if I could bring in our audience now to ask questions, I'm glad to see people have been firing in questions and perhaps tip off a couple of people who have been particularly active in asking questions. And I see that Tessa Richards has been asking some questions. And I'm particularly interested, in the discussions that you're having about involving patients, in the COVID-19 response. So Tessa, would you like to sort of come on? Would it be okay if you were to sort of come on, if we were to promote you to be an honorary panelist and you maybe ask your questions directly of the panel? And I'm not sure if my colleagues can tee that up for us. Otherwise, that we can ask it on your behalf. So I'm just seeing now on the gallery view if we're able to bring Tessa up. Yes, there's Tessa. So Tessa, would you like to unmute yourself and feel free to ask any of the questions that you were raising? But I've got a particular penchant for this one about involving patients in the whole process of planning services. Tessa's still muted. So maybe if we can ask that on your behalf, I just need to flick back to the Q&A and then I'll be able to ask that on your behalf. Yes, so Tessa's asking, how are patients being involved in co-designing new services and new platforms? Everyone's talking about, the importance of accountability and services being delivered, what people want. Are we seeing, do you think, through COVID-19 and that in any case, cancer services taking into account more and more the views of patients in designing services? So I don't know, who would perhaps like to kick off with that one from the panel? Mariana in Brazil, Mariana, you unmuted in Romania there. Sorry. So would you like to kick us off on that?
Yes, and if you will allow me, I will give you a quite good example. I think that the patients, we have now, time is changing and many patients go into IT, many of them, they have experience in IT, or many of them can collect around themselves the small IT group to actually start or to make a startup. And one of the good examples on the social networking, on mental support of cancer patients is a War on Cancer application. Because I know these guys, and actually when you have the personal motivation, which is the most important thing, to struggle to really reach the results. I think the patient's voice is the most important. So that's why when we have the community gathering of healthcare IT specialists, we always have patients on board, because patients, first of all of us, we are potential patients. Yeah. So it's not like we are separated here. But in other industries, like, I don't know, finance, banking, manufacturing, when we speak about the IT solutions implementations, we always think about the customers. When we come in and switch into healthcare system, very often, even I saw these examples, when we implement telehealth, it's very rare when patients actually participate in the process of implementation, which is critically important. And the recent document which I saw from American Medical Association about the process of telehealth implementation has this part. So we must put patients in the group of testing. Every single product we implement in healthcare system. So this is my answer. Thank you.
Great. Before I bring the others in, can I ask a specific question? Tessa's also asked another one, very much about information and the rights of patients to information, particular electronic health records. She says, do you agree that in the post-COVID era, the information playing field must be leveled and patients have the right to full access to personal electronic health records and test results at home in real time so that they can stay on the same page when they interact with health professionals? So do you think that, sort of potentially this is opening up more of a level playing field, that people sort of get much better access to their medical records, basically?
So here I would like to answer as a patient. As a patient, yes, I vote for this. And it's 100% and without any doubts and so on. But unfortunately, historically, we have a different regions where the approach to the patient information is absolutely different. So if we think about the Europe, it's, as an example, the post-Soviet Union territory. Yes, it's okay. So the patient is the owner of his or her information. But if we speak about United States, it's absolutely different approach. And this is a huge fight there to really switch approach to the patient-centric. So when the patient is the owner of his information and actively participate in the process of the treatment. So this is it. And we'll see how it will change in time, because I know that White House put a lot of, it was a blue button and other initiatives to change this, but it's also a resistance from the industry. So we should understand this. So there are historical approaches, but we should push as patients, potential patients, and from our side, HIT specialists, to make it possible, to do everything.
Thank you. And Carrie and Mariana, what do you think about this? Sort of particularly around sort of patient access to information. Do you see that changing in the new world?
Well, it's sorry.
No, Mariana, carry on. Yeah.
Okay. Yeah, I agree with Mariana. It's very hard to say. As a patient, yes, I'd like to have, but it really will depend on the local legislation and access to information. Well, I know that in France, you can have access to your medical records. You are well informed about, not electronically, but if you ask your dossier, you have it. But yeah, it's I really agree with that. As a patient, I always like to know what's going on, what's happening. But yeah, it really depends on legislation, and hopefully we all want more transparency in all subjects. So that's my opinion.
Rob, yeah, and thanks, Tessa, for the questions. On the first one, I think that we have seen, certainly in the UIC community, which is 1,200 organizations in 190 odd countries, a certainly a rapid movement to the available technological solutions that are available to deliver services to patients. And I think while there's been various degrees to which patients have been involved in the design of those, what, as Mariana said, is that they've actually adopted things that the patient's already using. They're already using WhatsApp. They're already using Facebook chat. They're using the infrastructure which is available in order to reach out to the community, whether it's from an oncologist to the patient or the patient support to the patient. So the degree of integrating patient views on that, I think, has been less than maybe if it was a bespoke design on a system for a particular hospital, whatever it may be. And then the second question, I think that we live in an era where over the last 10 years, I've seen that there's been a movement towards ownership of your own data. And whilst I agree with Mariana that country by country, there is different cultures, different political systems, different understandings about who owns what data and who could do with it, do what with it. I think that, you know, if we look in a 10, 20-year timeline, the degree of ownership of your own data will increase and increase and increase. And I think that's a natural consequences of the ability to collect data, either yourself through your own diagnostics, but also that the systems themselves have got to cope with a massively increasing world population. We can't spend infinitely on health. So there'll be a driver for efficiency, and efficiency has got to be putting information in the people who can use it most to avoid disease, or they can present themselves early to be treated. So I think that we're at the start. And there's a quote which I love from a paper I read about telemedicine. It said, "The genie is out of the bottle. It's going to become the new normal." So I think Mariana's got a career for life in what she's doing. I think the genie is definitely out of the bottle, and the investment that we'll see across the world in telemedicine and the application of new systems to embrace patients' requirements and to support them through their journey, I think we'll see a major change in the next 10 years.
Great, thank you very much, Carrie. And of course, remembering that the parable of the genie in the bottle, you know, the genie started off as being very benevolent and then was quite malevolent, really, wasn't it? So you know, there are very important lessons to be learned there. And you know, looking at technology and the benefits it brings, you know, and going back to a point that Mariana was making about making sure that it's equitable. And we've got a specific question from Rosie Tasker about this here, and I'm just wondering if we can bring Rosie in, or whether you know, this I'll need to ask this. So we'll just ask my colleagues, you know, if she can quickly bring in Rosie, if she's prepared to do that. But otherwise, I'll be able to ask her. There's Rosie, and Rosie's unmuted as well, so it's looking good. Rosie, would you like to ask your question?
Thank you very much, everyone. It's been a really, really interesting discussion. I think the question from my perspective is actually how to sort of pick up on the point that Mariana was making around ensuring that the technology that we introduce in these innovations are equitable. There's been a really strong focus on sort of e-health and telehealth solutions as part of the COVID response. And actually, how do we make sure that those are equitable in and of themselves, recognizing that a lot of these are developed without the input of older populations, who are often the majority of cancer patients in many countries. So actually, how do we make sure that that doesn't maybe perpetuate a series of inequities? Would be really interesting to hear from the panel.
Exactly. So how do we sort of stop this perpetuating or exacerbating even inequalities? Mariana, maybe can I turn to you in Brazil about that first? You know, sort of there's
Yeah, well, I completely agree with Rosie. I think it's a very, very good point, because you have to think how, well, about health literacy, about access to the technology. And well, it's not only the access to technology, but also the how to use, we see what's happening with, well, Facebook, WhatsApp, and everything that could, you can have a lot of misinformation spread around. So I think, yes, it can increase the inequalities if not worked very well. So that's why we need to target fragile populations and recognize those who are more in need of having more attention, and some people, they are just not suitable for using these technologies. They will prefer to have a proper physical consultation or something like that. So, but yeah, it's not only about ensuring the access to the technology, but there's a lot of things behind that to make people benefit from this. Well, I hope is that okay, Rosie?
Great. And Carrie, Mariana?
Yeah. Robert, may I add something?
Please.
Yeah, so thank you. First of all, thank you, Rosie, for this question. And actually, there are already some researches about how the elderly population use the telehealth opportunities. So, and there is a statement, there is a conclusion that it's difficult. So there no doubt it's difficult. So, and not only because for them it's difficult to adopt to the way how to communicate, but also for many old people to visit to actually clinician, it's to go out to communicate. Yeah. So, and from this point of view, I think I have two good examples worldwide. So one example, so we should look at the countries where the elderly population is quite big. It's Japan. And we know that they use a lot of digital devices, robotics, to somehow build this connection between the old people, yeah, elderly people, and clinicians, yeah, to monitor them all the time. So we can use this example. And another good example is from Finland, which I saw from Oulu University, where they have communities, local communities from the city, in every actually digital health solution which they are planning to implement. First, they test together with local communities. And that's why how people feel that they would is taken into account. Yeah? So the same way, slowly, one by one, we cannot implement this in all countries, but I think it's a good approach. So when you take their solution and then you test with the key audience, yeah, including their elderly population.
Great. Thank you. Thank you very much. Carrie, yeah, please.
Well, first to declare a conflict of interest, Rosie actually works for me. So I have to declare that. It looks like it was a fixed thing. I didn't know Rosie was going to ask a question like this. She should have tipped me off beforehand. I think that what we've seen in the last few years is that technology has been really much for an early adopter market. And there have been lots of great trials and as Mariana just said, examples of where technology has solved a specific problem and it's been rolled out in a way which has been sensitive to the access challenge for those in low middle income countries or those who are in lower socioeconomic groups. I think, again, another positive about COVID is that because everyone's been in it, I think that we've seen a lot of innovation being adopted by others, older people become more familiar with the use of apps or telemedicine or whatever it may be. And I've also seen that governments are using this to reach into communities which is more difficult to reach because it's cheaper to reach them than sending out a community nurse or whatever it may be. So I think, I won't go back to the genie bottle, but I think what we're going to see over the next few years is that the mindset has now changed. And we may not be able to point fingers at therefore that happened. I think the mindset's changed because of the consequences of us using it so much and because people become familiar with the value of it. And we have to, admit that there is a lot of technology in the hands of the lower socioeconomic groups. They do have the iPhones, the phones, etc. in many countries, in many suburban areas which are poorer. So I see that there will be a consequence of this and it will become a means through which we can improve the education of individuals and societies on health prevention and also early detection, which is critical in cancer control, and then the access and the servicing of them as patients if and when they do get cancer. So I think there could be a positive consequence without us doing too much.
Yeah. Fantastic. Thank you very much, Carrie. Now, just looking at the questions, I can see that James Maxwell has been very active and has 2 or 3 questions, all of which cracking questions, actually. So I don't know if I can bring James in, and you can decide which of your questions you'd like to pose to the panel. They're all very good. Hi, James. If you'd just like to unmute yourself, or should I be asking the question on your behalf? Yeah, we're going to hear you. Hi, James. Would you like to ask your question? I think he might be struggling to unmute. So maybe I'll sort of pick what are the questions that he was going to ask of us. Yeah, so I think particularly, this one, how do we ensure commitments are actually implemented? This comes back to the accountability question. We had a very interesting discussion earlier with the UHC 2030 group. We're helping produce the world's first accountability UHC commitments report. So how do we hold governments to account? They make great pronouncements about extending health services and access to records and things like that, but how are we going to make sure that these are actually implemented and deliver good value for money? So your thoughts on accountability mechanisms, please, panel.
Well, perhaps I can just jump in now. I mean, this is where civil society does play a key role, is holding governments to account on what they actually declare they're going to do. And I think active advocacy should be fundamental to all cancer societies and patient groups in any country, and that they should be pushing for change from governments and then holding to the account. That's part of the advocacy model, and it should be pushed. I think from a UIC perspective, where it can be augmented is where there is appropriate pressure put on, for example, the UN system or the World Health Organization, so that we are able to get resolutions that governments sign up to. So it becomes more than just an in-government commitment. It's actually a national commitment, which is held at a global body like the World Health Assembly. And I've been really quite impressed over the last few years, the way that member states have galvanized action around resolutions, like the palliative care resolution, the cancer resolution, and even this week we've had the announcement about cervical cancer elimination, which is the first time the world has declared that we're going to eliminate a cancer. Great news from Dr. Tedros and Nono and the team. And I think once that's in place, then the reporting mechanism can take place from member states, and they don't like to see themselves reported badly because they're comparable. And so there's another mechanism through which we can actually put pressure on countries around the world to fulfill their global obligations. And organizations like yourself and Lancet commissions can equally follow those commitments and report country by country. So I think there is some value in global commitments and then measuring progress country by country so they can see where they are.
Mm-hmm. Great. Thank you very much. I think we have maybe time for one more question from the floor, as it were. And Mark Lodge, Mark, would you like to come and join us? That you're asking a very interesting question there. So I don't know if we can promote Mark and unmute him.
Yes, all right. Thank you. Hello, Carrie. Hello, Mariana. I'm Mariana. Thank you, Rob. This is a question that goes very much upstream. Does the panel think that the anxiety over climate change and the experience of COVID-19 might be enough to change the post-1980 political consensus of the benefits of state retreat, deregulation, and leaving social determinants of health to civil society, and move it towards accepting its responsibility for health as outlined in the Alma Ata Declaration? Or will post-COVID, will government go back to its old habits?
Big question, and I think a super question to end the whole series, really, because this is very much bringing the whole health and health agenda into the Build Back Better, looking at the implications with sort of green growth, climate change. So really asking the panel to think about that, sort of putting cancer services in the perspective of UHC, but the whole health for all agenda. Do you think now is the moment?
Well, Rob, I think we should pass that over to James and Rosie. Mark, as ever, a very insightful and difficult question, and I'm so glad that we've worked together for so many years. I think I'm not a great fan of the phrase "build back better," by the way, but I get the gist of what it's trying to do. I don't think that we will be going back. I don't think it's easy to prescribe how governments are going to react to the situation at this stage. And we're in very early stages of dealing with COVID in many countries. And as we've seen, the political solution in Brazil is very different from Switzerland, for example, or the US or UK. But I think, if I understand your question correctly, do I think that governments are going to take a more proactive role in addressing some core societal challenges like global warming, health, and also the distribution of wealth in the future? Then I think the answer would be yes, but I don't know how much. I don't think we're going to go backwards. I think we're going to go forwards in a far more responsible political way as a result of what we're seeing at the moment around the world.
Thanks, Carrie. Can I ask the two Marianas their thoughts on this as well? You know, how do you see, you know, as moving forward and on these broader social determinants issues?
Well, yeah, that's a really hard question. Well, I really don't know how to. Yeah, it's a very difficult question to ask. And
I mean, maybe in the Brazilian context, Mariana, you know, sort of thinking of how things have got very politicized, and you know, the battles over the Amazon.
Yeah, that's what I'm thinking. If I think in the European context, I think things are improving, and while going to the all the discussion post-pandemic, taking account the climate change and everything. Well, I think also there is some pressure also on the governments to act actively on this, and economical pressure does work. So I think that if it changes this through economical pressure.
Mm-hmm. Mm-hmm. And Mariana in Romania, what your thoughts on how we link these agendas together?
I would prefer to keep what Carrie said, because I'm actually from the post-Soviet Union country. So, and here, I don't think that it will change, unfortunately.
You don't think
it's yes, because, you know, even now the response on COVID-19 pandemic is kind of, you know, the fight who will faster make vaccine, which means that who will faster make, then they will solve the troubles, and then it will not be actually the reason to change. Yeah. Mm-hmm. So you will just switch everything back. Yeah. So, but looking at what is happening in European Union, of course, we are very optimistic here. And also, I'm very optimistic personally about the new generation coming. Because we saw all these, you know, let's say millions of teenagers supporting the global climate change fight. Yeah? So they just by themselves, they went to the streets and they actually thought about this. Yeah. So I think that it's not only about the government, it's also about how we feel ourselves as a community, and it will change for sure. And in this point, I'm very optimistic. I'm looking these young guys to come and help us.
Absolutely, absolutely. And I think, you know, that's very much, you know, where a lot of people are thinking, really, that you know, that if we are going to have this sort of better society, if we are going to move, you know, to health for all, it really is up to the younger generation, I think, you know, to take this action and bring around political change. And you know, that we have seen in recent years really sort of quite reactionary governments come in, you know, sort of that's very insulated, very xenophobic, and climate denying. You know, we know the countries we're talking about here, and you know, some of these countries have got elections coming up in the near future, and you feel that, you know, the opportunity to change things in some of these countries is with the electorates in these countries in the coming months. It's not guaranteed at all, you know, sort of. So I think, you know, there's a lot of alarm and uncertainty around what's going to happen in the US presidential elections in November. And there is an opportunity to bring significant change in countries like the US as going forward. So I think, you know, we recognize that, you know, there's a huge role for evidence and science in bringing it to the policymakers' attention. But, you know, what really is going to bring about change, I think, is political pressure as well, really. So this is very much the focus of our work at Chatham House, and it's why it's been an absolute pleasure to work with you through this series. And we're extremely grateful for Merck Sharp & Dohme for sponsoring this work, you know, looking at, you know, these different areas of the effects on the elderly and on cancer services, but really recognizing that, you know, ensuring that services are going to be distributed efficiently and equitably to elderly people, maintaining cancer services, is going to be as much a political process as it is a technical one. And that's very much the role that we see ourselves as bringing together the communities, the scientific community, the academic community, with the economists, but with the politicians, to make sure that we do make sure that we extend services going forward. So thank you very much indeed for the panelists today, and for the participants for asking such insightful questions. We thoroughly enjoyed this series, and we hope to do more of these going forward. That, you know, this is new way of working, and we've been learning a lot through this process. So thank you very much indeed for joining us. Stay well, everyone, and, you know, wishing you all the best for the future. Thank you very much indeed. Bye now.
Thank you.
Thank you.
Bye-bye.
Bye-bye.